Welcome, ladies. How are we this evening? Did everybody enjoy some food? There's plenty of left out there if you want to partake in some more, and there's water in the back in case you're thirsty. So first off, I would like to welcome some providers that are in the audience tonight. I think we have Lindsay Reamer and Caitlin Parmenter. Are you here? You have to stand up if you are in the audience. Lindsay, Caitlin? Oh, maybe they didn't make it in. Well, we have two physician assistants who are here with us this evening, enjoying the evening, and I just wanted to introduce them if I could. So for the evening, I want you to thank the volunteers who helped do smoky eyes and hand massages and jamberry nails. So please recognize those ladies as you see them. They do volunteer to come out and make these evenings fun. So we are going to have another treat from Guess Who, our aspiring acapella group. And then I am going to tell you a little bit about, you know how I always like to talk about the subject. I've talked about shoes and my love of shoes. I've told you about why it's important to protect yourself against stroke, because my brother had one. We talked about suntan lotion, and tonight I get to talk about the girls. And I think, even though Travis is in the room, I think it'll be a discussion we can relate to. So first of all, I'd like to call up our aspiring a cappella group. Are we all here? Oh, no, we can't do it without the soprano. Peggy. Here she comes. Okay. And leading us off will be Kathleen Orminsky, the director of our emergency department. She sings the low notes. And then Peggy King, who keeps our CEO in order. Not easy. Rhonda Alft, who keeps our ED doctors and our quality department in order. Also not easy. And Cindy Orzel, who is in human resources and makes sure we get paychecks every 2 weeks. Yay! So go for it, ladies.
We have a special song for you tonight in honor of the girls. So we hope that you enjoy it as much as we've enjoyed putting it together.
My cha-chas may not be firm, they say more every day. I can't get in the way, but I love them, love them, love them. I love the way they bounce and sway. How they bounce and sway, but if they do not feel fine, I will get them checked out. Get them all checked out. It's time to get that mammogram. Do a self-exam. Let's hear it for the girls. Let's hear it. Let's give the girls a hand. Give the girls a hand. Let's hear it for our tatas who have a plan. Got to have a plan. You have yours and I have mine. Let's all raise a glass of wine and celebrate. If one day you feel alone or have a little pain, you should never just ignore it. It's gonna cause you stress and strain and make you go insane. You may need an ultrasound or get an MRI. Get an MRI. No matter what the test
have time at the end of the evening, we'll ask for an encore. I think it's only right. By the way, Lindsay and Caitlin, I don't want to call you out, but there they are in the back. So 2 PAs, they're over at the doctor's clinic, and they're terrific. They, in fact, did our Check Your Neck presentation. So thank you for joining us this evening, ladies. So for my introduction tonight, I researched the history of bras and found out that it just wasn't all that interesting. I found out that there was a woman who developed the handkerchief bra. It was comfortable, it made sense. And a man who developed the bullet bra. That makes sense too. So while I was doing this research, I came across an interview with a Dr. Kirtley Parker Jones, who is a practicing OBGYN and the vice chair of education at the University School of Medicine in Utah. Dr. Jones' interview was about the problem of being lopsided. Do you know what I mean by this? Anybody? I am talking about looking in the mirror and noticing that for the first time that one breast is larger than the other. I'll have to confess that I'm one of those lopsided women, and I have always blamed it on nursing my children on one side more than the other. However, I discovered that my theory was very incorrect. As it turns out, women are not completely symmetrical. Who knew? Every woman who had their breasts enhanced will probably not be completely symmetrical either, just because of the nature of who they were before they had them enhanced. So there are 2 breast buds. They start growing at the beginning of puberty, and sometimes one grows faster than the other. We don't particularly understand why. It's normal for one breast to be as much as 20% smaller than the other. 20%, ladies. Seemed kind of a lot to me. One breast may hang a little lower. Not that any of our breasts hang, of course. But if one breast seems to be a little lower than the other, really it's just normal. So how common is it? In fact, 90% of women have this disparity, so don't act like you don't. Now, what about breast size? What's normal for breast size? Well, anything in the range of an AA cup to a DT cup is normal. Pretty wide range. So what makes large breasts different than those of us who have small breasts? Well, it isn't the amount of breast tissue. It isn't the amount of tissue that is able to lactate or produce milk. It is how much fat is in the breast. Some women simply develop and deposit it in their breasts more than others. Okay, so I have a question, and I'm going to ask this to all the ladies out there that have this question. Is there any way I can naturally change the size of my breasts, or do I have to get an add-on? Well, the best way to naturally change the size of your breasts, so I found out, is to get pregnant. And really, ladies, that's just not going to happen to me right now. And the thing about that is that after you're finished being pregnant and nursing your children, oftentimes your breasts get smaller. So we're all very fortunate to have it's on the back page. So if you are within that normal range, here is what I think. Count your little breast blessings, all you small-breasted women, because you have quite a few blessings. And those of you large-breasted women, count your breast blessings too. It's better to count your blessings than add or subtract from what you were given. And that's my message for this evening. So now I get to introduce 2 very fine physicians who live in our area. Dr. Miller will speak first. She attended Mount Sinai School of Medicine and completed her residency in general surgery at the University of New York in Buffalo. She is board certified in general surgery and is a fellow of the American College of Surgeons. She is also trained in advanced wound healing, hyperbaric oxygen therapy, and is the trauma director for Aspirus Riverview Hospital. She enjoys teaching and precepting fourth-year medical students from the UW School of Medicine and Public Health. Dr. Miller married her college sweetheart, Dieter Miller. Together they have 3 children, a daughter in college, Salem, a son who is a senior, and another daughter who is 11. They also have a golden retriever, Goldie, you know how I have to bring up the dogs, and a naughty little furry thing called Sally. Dr. Miller is an active scout leader for both Boy Scouts and STEM Scouts. In fact, this year she went on a 2-week hike with the Scouts and spent all that time hiking on a twisted ankle. I know, that's what I said. Dr. Olson attended the University of Wisconsin School of Medicine, did a transitional intern year at Tucson Hospital Medical Educational Program, and completed her residency in radiation oncology at the University of Iowa Hospital and Clinics. She is board certified in radiation oncology and is also a clinical assistant professor of human oncology at the University of Wisconsin. In addition, she is a member of the American Society of Therapeutic Radiation Oncology, the American Society of Clinical Oncology, and the American Medical Association and the Wisconsin State Medical Society. She is married to Dr. Aaron Olson, who is a family medicine physician that practices out of our Rome clinic. Together they have 4 young children, 3 girls and 1 boy, as well as a golden retriever. Dr. Olson's passionate about the benefits of physical activity. She serves on the board of the YMCA and is also a program advisor for the Live Strong program, a program that helps cancer survivors integrate physical activity into their survivorship plan. Every year you will see Dr. Olson participating in the Renaissance Run, sometimes while pushing a stroller. We are very fortunate to have these 2 such incredible physicians practicing in our community. I would trust them with anyone in my family and can recommend them without any hesitation to you. Please welcome Dr. Millers and Dr. Olson.
Yeah, that's our pointer.
Okay, perfect. Looks like I already advanced it on you.
That's okay, that's in the first slide.
Okay, so that's perfect. All right.
Yeah. Hi, I'm Dr. Miller, and I think I recognize some of you from the wound care clinic talk I gave in the summer. So it's good to see you again. Welcome. This is Breast Cancer Awareness Month, and this is appropriate talk. And also in my practice, what I see is an increase in breast cancer in October. I think it's because it's Awareness Month and everybody's getting their mammograms. So it's not necessarily there's an increase in cancer that's happening in October. I think people are getting their testing done in October. It's not unusual that I have had patients as young as 22 have breast cancer. And they say the only reason they found it was Breast Cancer Awareness Month. There was a commercial with Susan G. Komen. They did a breast exam and they found a lump. When he asked them about their family history, yes, they think they had a grandmother or maybe a great-grandmother. But breast cancer can affect everybody. 1 in 8 women get breast cancer. And so this is a talk about why, let's hear it for the girls. We have them. Let's try to protect them. And sometimes we may not be able to, but if we can diagnose breast cancer early, we have a much better chance of surviving it as well. Okay. So according to the National Breast Cancer Foundation, in 2015, there were more than 3.1 million U.S. women alive with breast cancer. And that we have to, give credit to modern medicine. Breast cancer 40, 30 years ago, 50 years ago, was essentially a death sentence. Now breast cancer is like, okay, yes, you have breast cancer. We'll treat it. We'll get over it. There's other things that are far worse at this point. Lung cancer, is the number 1 cancer that affects women and men. Breast cancer used to be number 1. It is not number 1. And in terms of deaths in general, heart disease is number one. So the reason we're seeing that many women is because we're diagnosing it early, okay? Early screening is very important. Screening, we usually recommend a baseline screening as early as 35 for some, but usually starts at 40. If there's a strong family history, you can go down as low as 35, or if it's somebody who had breast cancer at 35, I would recommend to my patient, the youngest person would be starting 5 years earlier than the person in that family. So 40 is not, there's variation. So 40 is the guideline, but we look at the family history and say, okay, based on this family history, we may start earlier, okay? There are different factors that affect breast cancer. There are some that we can control and some we can't. So some of the things that we can control, we can't control age. The biggest factor for breast cancer is age. Women get breast cancer. It's a disease of postmenopause. We do have women who do get breast cancer premenopause. Those are a little different. They sometimes can be more aggressive, and there tends to be a much higher family history. But it is a cancer of, postmenopausal women. And other factors, personal history, family history, reproductive history. With reproductive history, over here, women who have a slightly higher risk of breast cancer if they don't have any children, or they develop their menstrual cycle, their menses at a very early age, or did not have any children after age 35. So what's happening there is that the breast tissue has unopposed estrogen. And so that's affecting the breast because estrogen can feed cancers. So if you have a long period where there's no break in that cycle, there's an increased risk of breast cancer. So getting early menses, someone who can have as early as 9, and then somebody who has no children. So that person who has their menstrual cycle at age 9 and does not have a child until after 35 or never has children, they're a much, much higher risk of getting breast cancer. Okay.
Should I say something about radiation?
Yes.
Okay. So I'm going to take the mic from Marjorie here. On that list, you're going to see that radiation is listed as something that can cause breast cancer, and that is true. But let me explain that. That is an issue that we see when we're treating younger children, adolescent girls. That's a time when lymphomas tend to be diagnosed. And for some of the treatments for those young girls, we need to do radiation to the lymph nodes in the armpit and the lymph nodes coming up the neck. And we're catching a lot of that breast tissue while it's developing, which is a very sensitive time. So the increased risk of breast cancer comes from prior breast radiation, and typically is in adolescent girls. And I just like to clarify that because at this point, yes, everyone in this, I don't see any adolescent girls out there. Everyone who'd be exposed to radiation now, that is not nearly the same risk factor than what the information was pulled for this slide, especially if we're not treating anywhere near the breast. So if you need to have radiation to a different part of your body, that's not going to increase your risk of developing breast cancer.
Okay. And also, you see on the slide, race. Race is another risk factor. Women, black women, Ashkenazi Jewish, people with Ashkenazi Jewish heritage have a much higher risk. They're also may be more predisposed to have a genetic factor. So that's one of the things that we see with race. Okay, and then genetic factor. The genetic factor that you might hear about is the BRCA gene, the breast cancer gene, BRCA1 and BRCA2. And there you might see in the family just several women, grandmother, aunt, mother, cousins. those will, when we see that, it will prompt us to do a gene testing. And BRCA is one of them, but there are other genes that we test as well. So it's not just the BRCA, okay? And if people who have had treatment with DES, I don't think there's pretty much that anymore. Then there are risk factors that are not, that we can control. So the other ones really can't control. You can't control your race. You can't control when you got your period. But the other ones that you can, okay, so there are studies that have shown that certain factors like obesity, that can increase the risk. Not having children, we talked about that too. Birth control pills, you might see that's controversial. There are several mixed studies about that. With birth control pills, we've seen that there's a slightly increased risk of breast cancer. The studies were done when the birth control pills were really high in estrogen. So most of the birth control pills now are low estrogen, and there has not been any risk involved with the low estrogen, but the ones that are high estrogen or a component of estrogen and progestin, those can increase the risk. And also the shots, Depo-Provera, that also sometimes you might see an increased risk as well. But when the Depo-Provera, which is a shot that stops your period for long periods of time, that risk goes away after several months. With the pills, the breast cancer risk, again, that was the high estrogen. You can stop that, and that risk of breast cancer will still be there for about 10 years. After 10 years of being off that birth control, the risk goes back to the normal population. Breastfeeding, alcohol has been seen with higher risk of breast cancer. And again, that's a mixed study too. They'll say, well, less than 2 a day will not increase the risk. These are people who are drinking quite a bit of alcohol. Hormone replacement therapy, that is a mixed study as well of people having higher risk of breast cancer. Now, okay, so what is breast cancer? Our breasts, I'll show you a picture of a slide of what a normal breast looks like. Breast cancer is when you have your cells, you have ducts, and they're supposed to be aligned in a certain way. And when those cells start changing, first they might get a little plump, and that's called atypia. And sometimes that can be seen on mammogram. That's very rarely seen on mammogram, but it's just a little change that they'll see. And when we take out that tissue, it's atypia. The cells are just plump, but they still remain the same architecture. So there's no variation. When we see that, that signals that there might be a pathway to breast cancer. So that's removed, and pretty much that's all you need to do. People who are at higher risk of breast cancer who have atypia, sometimes we may send them to Dr. Kirschling for risk reduction. So they may be placed on a anti-hormone therapy to help decrease their risk. But for the most part, just removing that tissue is enough, okay? So when these cells start to divide, also, they can crowd inside that duct, and the first thing you're going to see is a stage 0 breast cancer, or what's called DCIS, ductal carcinoma in situ. Sometimes people call that precancer, some people say it's not cancer, but what it is cancer cells, and if that's left untreated, it may stay in that stage forever, or it may change to invasive cancer. We don't really know who's going to change and develop cancer, because 60% may go on to develop cancer, 40% won't. So everybody's treated as if they were going to get breast cancer, and that's removed. Okay. Most time, the most common breast cancer begins in the duct. So you can see here, this is a normal breast anatomy, and this is what I was talking about, the duct. So here's your breast cells, and if they get just a little plumper, that's the first thing we see. That's called atypia. If they start to crowd inside the duct, then that's DCIS. So your breast consists of ducts, and here these are lobules, and here you can see dilated milk ducts. Nipple is over here, and out, this is the true breast tissue, and outside is the fat. So breast size, you know, may be determined by the amount of fat. Some people just have a little more, some people have a little less. And here, this is your pectoralis major muscle, and then your rib cage. This is what we mean by DCIS. You can see that the cells are started to divide and they're crowding inside the duct. Outside, you have what's called a basement membrane. As long as it doesn't violate that, it stays as DCIS. But DCIS can travel, even if it's in the duct, it still can travel up the ducts to several ducts. This is invasive cancer, where you can see it breaks through the basement membrane, and that's just a cross section over here. So from here, it can spread to surrounding tissue, and this is when you have what's called carcinoma. There's another type of invasive cancer that you can develop rather than the duct, which is the most common type of breast cancer we see, is ductal cancers, but you can have lobular carcinoma as well. The lobules are here, the cancer starts here as opposed to in the ducts. So this is a lobule, and again, if it did not violate this membrane, it would be lobular carcinoma in situ. That is not a cancer. It just lets us know that that patient is at a higher risk of developing cancer, but it's not a cancer itself. But once it breaks through, then that becomes invasive cancer, lobular carcinoma. And whether it's lobular carcinoma or invasive ductal carcinoma, they're both treated the same way, you know, with surgery to remove that area. And then depends, radiation, it depends on the size, radiation, maybe chemo, not everybody gets chemo, and maybe hormone therapy as well. And metastatic cancer, which is stage 4, this is where breast cancer can go everywhere. So once it breaks the basement membrane, we talk about that's how it can spread. The vessels run on the outside of those ducts and the lobules and the lymphatics as well. So it can go into those lymphatics, and from there travel in the vessels, go into the bone, go into the liver, go into the lungs, and then lymphatics into the lymph nodes. You can see these are lymph nodes, lymphatic tissue, and then from there they can go under the arm where you would have lymphatic tissue, your lymph nodes, or it can go into other lymph nodes that are closer to the rib cage. Okay. What are the more common signs of breast cancer? One you can see, most common is just a lump. That's far gone. Most of the time we're catching them with mammogram, which is what we want to see. We want to catch it at the earliest stage possible. When there's a lump that's palpable, that could mean it's a much higher stage. We want to catch it in a stage 0, stage 1. These are the most curable stages. That doesn't mean that if it's not stage 4, we can't extend the life as well, but we want to catch it really early. But finding a lump is one of the most common signs besides the mammogram. Other signs that you can have are nipple discharge, because those cancer cells are invading the the duct, irritating it, and that can cause a bloody discharge from the nipple. Although bloody discharge from the nipple 10% of the time will be cancer, 90% of the time will not. It could be just a little wart that's in the breast, but we still have to evaluate that and make sure that it's not a cancer. Okay. Other signs that you can see: changes in the nipple direction where it pulls in. It's not uncommon that I have women come to my clinic and I see their nipples are turned in and they're like, oh, it's been like that since I was, 10 years old or 8 years old. So those are not what I worry about. It's the one that their nipples were always pointed out and all of a sudden they start noticing that it's turning in. That's not something you dismiss. You should get in right away to be evaluated. Other signs, which is a different type of breast cancer, which is inflammatory breast cancer, is where you may notice redness of the breast. Okay, you may also know a change in the size of the breast. Nan talked about most of the time we are uneven. If you know your breast well, but all of a sudden you notice that one breast seems to be getting larger, that could be a sign of breast cancer. If it's red, first thing the patient's going to do is go to their doctor because it's red and you think it's an infection. It's not uncommon for their primary care doctor or their internist to start them first on an antibiotic because that is normal protocol. Just make sure it wasn't an infection. And if it's not clearing up within 2 weeks, that's usually a sign that the patient needs to be seen by the surgeon. Get a biopsy because this could be an inflammatory breast cancer. Inflammatory breast cancer is when the cancer goes from the breast tissue and it's now invading the skin, the dermis, the lymphatics, the tissue around, so it's more noticeable. Okay. Other things you can see are itching, scaly tissue around the nipple and areola, and pain. Usually they say breast cancer is not painful, but if you have a spot in the breast that's not, that's very tender, it's not going away, that needs to be evaluated. It could be breast cancer. Sometimes it could be just a cyst as well. And if it's a cyst, we'll know, we drain that, it goes away. So what I see in my practice, again, is most of the time the patients are being referred because they have a abnormal mammogram. But again, it's not uncommon that the patients come in because they found a breast cancer lump themselves. Sometimes they'll come in and they found the lump 3, 4, 5, 6 months, and they're hoping it went away, it goes away. That's not acceptable. In this day and age, we can treat breast cancer, we can cure some breast cancers. The earlier you come to the doctor, the better the success rate. So I don't really like it when I have a woman say, well, the lump's been there for about 8 months, 9 months, and I'm like, why didn't you come in? Well, I was afraid it could be cancer. Well, yes, it could be cancer. That's why you need to come here. We want to take care of it early. Don't wait. Also, some things that I also hear is, the women, I'm like, well, the mammogram found a lump, and the lump is the size of a lemon. And I'm like, did you feel this? No, I didn't feel my breast. I don't touch my breast. Why? Your breast is part of you. It's just like looking at the face, looking at your face every day in the mirror. That breast is part of you. Get comfortable. Examine your breast. It's okay for your husband to examine your breast. Make it fun. It's okay. Okay, so take it down. But it's okay. I do have women who come to my office and they're like, yes, my husband found this lump. I like to hear that because their husband found the lump when it's the size of their pinky nail, as opposed to waiting and not examining your breast, or because you're not comfortable with just examining your breast. There's nothing shameful about touching your breast, doing your exam, finding a lump. It's okay. And if you're not sure if there is a lump, if you have a partner, have them feel it too. And they might say, well, no, I don't feel anything. Or they could say, yes, I feel something. Come in right away. It's okay. All right. So then we'll talk about, the treatments again. So like I said, from my standpoint, from a surgical standpoint, I usually try to get all the information. The biopsy is typically done by radiology most of the time. If they can't, for whatever reason, the breast is too dense, they don't think that they'll be able to get a good sample by doing a stereotactic biopsy, which is using a needle with the mammogram, or doing ultrasound guided biopsy, then they'll send them to me to get a biopsy. I don't like that as much because then the patient has to go through 2 surgeries, but sometimes we have to. But if they can get the biopsy first, which is 95% of the time, then they go to the operating room. I'll take out that area, whether it's a lumpectomy, and also lymph nodes. You know, if it's an invasive cancer, we want to get lymph nodes to help determine the stage and what other treatments that the patient may need after their surgical treatment. So once they're done with me, then they go to Dr. Olson and Dr. Kirschling to see if they meet requirements to have additional treatments such as radiation therapy or chemotherapy. And the guidelines for radiation therapy are changing as well. You know, something that we did 10 years ago may not apply today because there are new studies that are showing that some people may not need radiation. It may be overkill. Some cancers are a little more indolent or slower growing. They may not change, you know, adding the radiation might not give any benefit than if they did not have radiation. And Dr. Olson knows more about that.
Okay. So I will take over from here. Let's use this little scan thing here. I was not listening to Nan when she gave instructions. I was thinking about what I was going to say. So, what one is the pointer? Okay. I think that Dr. Miller covered most of these signs and symptoms already, so we'll keep cruising along. And if anyone has a question, just throw your hand in the air and ask, or if you would like to be like my children, just yell it out. And if I don't respond, yell louder, or just throw something or hit your neighbor, or whatever it takes. I'm used to that. Really, I don't mind, and you're all here to learn. And so we know what we like to talk about and think you want to hear, but really you know the questions that you have. So stop us and ask us. Oh dear, now I did something else. Oh, they're all appearing. Okay, there we go. So I think that we covered the prevention part. Mammograms are good. There's constantly debate about when you should have them, when they should start. The insurance companies sure like their recommendations more than what all of the physicians have recommended. And I know that they're changing and it's not always going to be the same, but you should engage in mammograms. Okay, that's a discussion that you should have with your primary care doctors. Find out when it's right for you and do that. That's how we catch so many of our cancers. Well, I've now gone through the entire slideshow accidentally. Okay, I'll let, we'll fix that. So let me talk to you about this radiation business and this chemotherapy business and this hormone therapy business, because Marjorie has the easy part. Yeah, everyone who has breast cancer says, get it out. I want the cancer out of me. And so in my mind, now I've never been in her clinic, I picture people just kind of like skipping in there, getting ready for their surgery, ready to do it. And then it's done. And she's like, and now you have to go to that cancer center. And then there's kind of this sense of dread, and people come and see us the first time. And really, what you know about cancer treatment today, specifically breast cancer treatment, cannot be based on what's happened to your mother or your sister 20 years ago or your friend 25 years ago, because so much has changed. So we've gone from doing big surgeries, removing all of the breast tissue, all of the lymph nodes, to less and less and less surgery. And we found that adding radiation ends up with the same cure rate as a major surgery. As Marjorie was alluding to, we're even starting to explore who doesn't even need the radiation. So what we do when you come to the cancer centers, typically you'll meet with Dr. Kirschling, who's a medical oncologist, and then I'm the radiation oncologist, and we try to figure out what is your risk of this cancer coming back if we don't do anything else, versus what benefit can we give you with chemotherapy, with radiation therapy, and with hormone therapy. We now have the ability to test your tumor for specific genes. So I'm not talking about the mutations that can be passed in families, but other genes that help us know if you're going to respond to treatments, if they're actually going to give you a benefit. So we're not going to say, well, you have breast cancer, you're getting chemotherapy. Rather, we run the numbers and we will be able to tell you you're likely to get a 5% or a 10% benefit by chemotherapy, so that you can think it through and decide, okay, if I can increase my survival by 1 percentage point, is the chemotherapy worth it? Versus if I can improve my cure rate by 15%, or I'm making up these numbers, but it is so individualized. Chemotherapy is not one drug. That's a name that we use to describe many, many drugs. And so a chemotherapy that your friend got for lung cancer is not the chemotherapy that you're going to get for the breast cancer. It doesn't have the same symptoms. So just because you're hearing the word chemo, don't panic. Radiation is what I do. So radiation is an X-ray. It is a very targeted X-ray, and in most cases we aim it just at the breast, though there's ways that we can aim it just where the tumor was located, or even insert radioactive material into the breast just to treat a small area. Sometimes we need to treat lymph nodes, and so the breast lymph nodes are under the arm and they kind of come up into the low neck area, and sometimes not. It's all based on your risks. It used to be that everybody got breast radiation after surgery, and now we're finding maybe if you're older, maybe if your tumor doesn't look so bad under the microscope, maybe if it was small and you took out a big part of the breast, we don't need to give you the radiation because you're not going to get enough benefit for it. Typical radiation treatments for breast cancer have changed while I've been in practice. It used to be that everyone would get about 35 treatments to the breast, and now we try to do it in 15 treatments to the breast with about 5 more to the area that the tumor came out of, and we are working on decreasing that even more. We're in the phase where we're studying to make sure it's safe. So with time, when we give this talk in 2026, it'll be, I think, fewer treatments still. You may get tired when you have radiation, and your breast might get a sunburn, but a lot of the incredible blistering and peeling and all of that, we don't see it anymore. It's new machines. Again, we cannot compare what you're going to experience now with what your friend had 20 years ago, 25 years ago. Radiation treatments take a few minutes, usually 6 to 15 minutes. It depends on the shape and size of your breast. And when the machine turns off, you are free to go. You're not radioactive. You can come to the Aspiring Women event that night. You're not going to lose your hair. Your immune system doesn't go down. And no, you don't glow. That's a common thing that people say to me. You don't glow. So it's a totally doable thing. You can keep working if you work. You can keep exercising if you like to do that. And if you don't like to, I'm going to try to talk you into it. Nan already gave away one of my other passions in life, which is some of the exercise, and it's an important thing to hear. When you move your body, your outcomes with breast cancer improve. And this is not an idea that I invented. This has been published over and over in medical journals, and it's becoming more and more common in the oncology literature. Walk slowly, 4 times a week for 30 minutes, and you're going to feel better, have less side effects, and decrease your risk of the cancer coming back. You don't have to lose weight, lower your blood pressure, change your blood sugars. None of that has to happen. You just have to move your body. So a lot of times women will say to me, well, what can I do? I got this cancer. She took it out. You're going to radiate it, but what can I do? Move your body. Take care of yourself. Decrease some of those risk factors. So I think the slides are back now, and I'll try not to be quite so excitable with that. Aside from lifestyle changes, you should follow the early detection guidelines. Yes, we've all agreed that mammograms are good. Prevention begins with action. Okay, we talked about typically 40 is when we would do that. But, if there's earlier family history, then we'll do it earlier. Ignoring them, that's not on the list. So that's not a reasonable option. The self-examination, do we have those self-examination cards that you can hang in the shower? Do they make those still? Yeah, so I'm not sure if we have something like that, but you can always look these up on the internet. And but basically, look at your breasts. Yes?
Would you speak to 2D versus now being offered 3D and the value or not of out-of-pocket costs for 3D versus insurance-covered 2D? And if you're going to talk about it, I'll wait.
No, we'll do it right now. I like that you held that up. That was nice. I felt really comfortable with that.
I like the 3D. I think Medicare now covers, from what the hospital told me, Medicare covers 3D. The other insurances, on the other hand, it depends on which one. For example, mine does, but I don't know if everybody else's does. I like the 3D. I recommend it because you can see a lot more. From my standpoint, you're actually moving through the breast, and there are areas where, you know, there may look like, let's say, a shadow or a spot, and you go through it, and it's just the way the breast tissue, you know, was superimposed on each other. But with the 3D, you can actually go through it and see this really is a spot, as opposed to just the way the breasts are squished together and a lobule. So I do recommend the 3D. You know, if you can afford it, go ahead. If you can't, I believe the hospital has a program where you can call the billing office and see if you qualify to have that covered. And they'll cover it. And it's a grant that was funded by the Susan G. Komen. So I do recommend it. I think eventually the 3D will become, you know, the standard of care as more and more women are getting it, and we're seeing the value of it. I think this year was the first year, initially when it first started, it was just trial, but Medicare realized the value of it, and I believe Medicare covers it. It's just all the other insurances, it's hit or miss. And I believe it's only 120? Yeah, about $100, $120, $130. So, you know, what's your life worth to you? $130? I think we can find that. So, and if you can't, again, the hospital does have a program.
When do they give you that option or that discussion? I've never been on the receiving end of that kind of option or discussion.
They give it to you as they're doing your mammogram. So it depends on when. If you had your mammogram at the beginning of the year, they weren't doing it yet. I think it was started around June. We started offering the 3D. So if you've had it before June, you probably weren't offered it. After June, I think they offer it. They just ask you, as you're doing your 2D mammogram, would you like to have the 3D added to it? It doesn't take any more time. I think it's an extra minute.
What's the difference between a 3D and an MRI?
Okay. Well, an MRI mammogram, those are nice. They're almost comparable, but the MRI, the problem with MRIs is that it will pick up on a lot of other things, and you can get what's called a false positive. And the false positive then will send you spiraling to biopsies and just to find out it was negative. So it does pick up on a lot more than a mammogram. The 3Ds are really approaching that, as opposed to the 2D mammograms sometimes can miss a lesion. The MRI overreads it, the regular mammograms underread it. I think the 3D is a nice middle where it's picking up lesions that are really real. Okay. MRI though are, you know, most insurance will not cover MRI unless it's part of a protocol where somebody has a breast cancer gene, then they will cover it. And they alternate the MRI with their mammograms. So every 6 months, that individual is having an exam. So June, they'll have an MRI. January, they're having their mammo. So every 6 months, they're, okay.
What do you recommend for atypical hyperplasia?
Atypical hyperplasia, again, like I said, that's on the pathway. So we usually remove it and make sure it's out completely. And sometimes that's all you need. But if you're high risk, or even not even high risk, if you want to reduce your risk, a lot of times Dr. Kirshen will start that patient on a hormone therapy, like estrogen or tamoxifen, to help decrease their risk. Okay. But once it's gone, you know, you can pretty much sleep soundly. But if you do have a strong family history, you may be a good candidate for risk reduction.
Why are mammograms not encouraged after you reach a certain age? I'm not sure I remember what age it is, 70 or 75, something like that.
This is 75.
And it's an age, and it's your health as well. Because what we're trying to do is pick up on cancers that are going to end somebody's life. So when insurance companies and the people who collect the data on the average lifespan, why would we be screening for a breast cancer when we don't expect someone to live long enough that that breast cancer would cause a problem. So instead of picking one age, you should talk to your primary care doctor. If you're a really healthy 75-year-old and women in your family are living a long time, then it might be in your best interest to continue the screening. So instead of giving a firm, once you hit this date, you're done, it's really when you start approaching that age, start weighing the potential benefits of continuing it versus the hassle and expense of continuing it.
Right, because they're thinking, well, the people who make these decisions, again, the insurance companies and the data they collect, they're saying, okay, at 75, if you find a breast cancer, even if you don't do anything with that breast cancer on a 75-year-old, that probably will not kill them compared to something else like heart disease or colon cancer. So that's why they're using that. But again, if you're from a family with longevity and everybody's living to 100, 104, 105, and you're very active, you might want to discuss that with your primary care physician or your provider about getting that mammogram continued. Okay, so that's why.
Yeah, I did question it, and they said, well, it's kind of like opening up a can of worms. You might end up with tests that you really, like you're saying, you wouldn't be ending your life, that there'd be something else that would finally do the end.
Yeah, and it's the same thing also with, this is off topic from breast cancer, the same with colon cancer. I think they recommend you stop screening at age 80, between 75 and 80. But again, it also depends on, the longevity in the family and how active you are, what other health risks you have and other health medical issues.
Okay, thank you.
You're welcome.
So one quick question about the 3D versus the regular mammogram. Last year I had a 3D. Would it be to my benefit to keep doing 3D, or could I go back to the regular? What do you recommend?
Yeah. I'm not sure. Yeah, you stumped me. I think I asked Dr. Lucas that, and I don't think you need, if you had one, you could easily do a 2D and maybe every other. Okay, it's really, especially since, the government task force recommends a mammogram every 2 years. Anyway, the physicians recommend every year, but the task force is every 2 years. So doing another 3D in 2 years is not unreasonable.
Yeah, I'm going to advance the slide while you ask the question, because I know I flipped through these. Okay, we did it. We did it. Guys, we did it. We got it. Now we can ask all the questions. And one thing that I like to encourage people, I find that people have a lot of crazy myths about cancer care, radiation, chemotherapy, these ideas that you may have in your mind that you've always kind of wondered about. Now is the perfect time to ask. I would much rather educate everyone on what it is really like, because I think part of in getting people to get their mammograms and to take care of their breast is to remove some of the fear of what those tests can find. So any question that you may have, no matter how bizarre you think it is, I can assure you, I have heard something more bizarre, and we're happy to answer anything to the best of our ability.
There was a slide there that had the alterable factors. It had exercise and breastfeeding. You didn't really key
So-
on those two areas. Good
Exercise.
things or bad things?
Exercise and breastfeeding are both excellent ways to decrease your risk of breast cancer. So for probably just about everyone in the room, we've passed the breastfeeding stage.
Would you please share the microphone?
Oh, okay. Exercise and breastfeeding are both really good at decreasing your risk of breast cancer. Probably not many people are lactating still or interested in doing so, so that probably is off the table for most women. But exercise. Exercise has some really amazing benefits for your health overall, and I think most people look at exercise in a really simple way, like we exercise so we look better in our clothes or we feel better, but it really is doing a lot more than what we realize, and it's not like going and running a marathon. You don't have to exercise in that way. It is as simple as moving your body. simply moving your body, and that decreases your risk of cancers in general. Part of it is that obesity can increase your risk of cancer. It's estrogen exposure, so you would think that exercising may decrease the amount of fat that a person has, but even if it doesn't, there are still benefits, and we're just starting to, I shouldn't even say just starting, we're at the tip of the iceberg on what the exercise will do for overall health. Dance. Yeah. Yes, dancing works. Speaking of dance, don't you dare stop asking questions, because my husband had to take all of our kids to ballet and tap. And they're 7, 5, 3, and 1, and if I get home too soon, I'm going to have to address that situation, just coming home from dance. So please keep asking questions. Till about 9. Go ahead.
So back in February, I had a mammogram. Okay, now fast forward to about 2 months ago, I had a knee replacement. About 2 weeks after I had a knee replacement, I started having a slight pain in my breast. Aggravating pain, not pain that hurts you so bad or anything like that. So I called the doctor, and she said, come down and we'll do a mammogram. And they did the 3D mammogram. Couldn't find anything. So now the doctor did not call me back. This is just about a week and a half ago. She did not call me back to say, we'll go forward and check on something else. Should I be worried about this and go back to her? Or forget about it as long as they didn't find anything?
So I think, I
Because
think
it's still hurting.
I think the answer is something is abnormal, and it probably needs a bit more evaluation. It's hard to know, because we haven't seen the mammograms and all of that, but it's not normal that suddenly you develop a new pain. Is it cancer? Unlikely not. It probably is not cancer, but it's something new and different that you've never had. I don't think that you should dismiss it quite yet.
Okay. So tell me, why didn't the doctor call me back and say, we didn't find
Oh
anything,
dear.
but come in?
Okay.
Why
Aggravates.
do some physicians recommend the 2-year mammogram instead of the every year?
Yeah, so there's huge variation in who's recommending what. There are all different groups who all have different opinions. The government has set out its opinions. Certain insurance companies have their own, physicians have their own. So what is at the heart of that is they have looked to see the appropriate ages and the appropriate numbers of time that we need to screen people in order to save a life from breast cancer. And so if you look at the data, it's not perfectly clear cut, and that's why every group kind of settles on something else, but somewhere between that 1 and 2 year mark in that window of age range is the amount that leads to saving lives from detecting the breast cancer. So it's not as simple as somebody just likes that number. That data is really pretty complex.
Do you see a time in the future where mammography might not be like so like this, so it doesn't hurt, but it's like it's really not that fun. So is there a way that think that they might come up with something?
So, okay, I haven't reached the magical age yet of screenings. I'm not. I'm sure somebody is working on it, but there's got to be a way to image that tissue in a cost-effective and beneficial way. So I'm not sure who's working on it, but I don't have any secret knowledge of that one. Go ahead.
I have a daughter who went into the clinic, and she had one breast was substantially larger than the other, and she had some pain, and they thought they felt some lumps. And so we wouldn't think she was getting a mammogram. That's when we found out about the 3D one. So we thought, okay, we'll get that. But they didn't recommend either one. They wanted her to have ultrasound. And with the ultrasound, they determined she had absolutely nothing abnormal yet. We don't know what it was, but it wasn't cancerous. Like the gal here said, well, it wasn't cancerous, so do we worry about it? Do we forget about it? It's still there. And what is the difference? Why would they recommend an ultrasound versus one or the other? We were kind of confused. she led us to believe that the ultrasound was the better way to go for her age, she's 19, and I guess for the situation. So,
Yeah. With particularly women under 35, or especially 19, the breast is very dense. So if you do a mammogram, whether it's the 3D or the 2D, it's just going to show just white tissue. That's going to be very hard to pick up on anything. The ultrasound is actually much better for younger breasts because they can pick up on cysts, they can pick up on lesions much better than the mammogram would. Okay.
well, then why don't they recommend that for young women, and then when they get to a certain age, recommend the mammogram? If they want to detect it early.
Well,
Yeah.
the age.
Age.
Age is the number one risk, well, being a woman and getting older. So it's extraordinarily uncommon that a 19-year-old would have breast cancer. It absolutely happens, but again, it goes back to looking at the number needed to screen in order to start saving a life. And because it's so uncommon, we don't screen 19, 20-year-olds. We only do something if a problem comes up at that age group.
But we still recommend our young women, our young daughters, that they do the self-examination and that, you know, and if they do feel something, then maybe that's what they should be asking for, talking to their doctor about getting an ultrasound versus a mammogram. I mean, that may be some education, because I knew nothing about that. I had a mammogram every single year since I turned 18. It was covered on my annual physical. Nobody ever questioned it. Every single year, and I'm 60, so I have 60, my age, so 40 mammograms, and it's like, you know, am I more at a risk for cancer because I've had so many mammograms?
Well, it's just unusual to start screening mammograms at age 18 or 19. You know.
That's what they recommend back then.
Yeah.
Here in Wisconsin, we're after that to the clinic. Or a little bit.
Yeah.
So,
Yeah, so much has changed. You know, cancer care in general is not the same. So the thoughts about how we should find it, the thoughts about what we should do about it, it is so different. And it's really amazing to me because I always have to pause and think. 11 years I've been doing this. And even what has changed in those 11 years is incredible. So I'm not at all surprised. I mean, it's an unusual recommendation that we don't make now, but that doesn't mean it didn't make sense to someone. And the way we manage breast cancer and find it and treat it, it's totally different now than it was 40, 35 years ago. Who else has questions? Go ahead.
How do you feel about the thermal imaging that some of the chiropractic places?
Yep, Marge was just mentioning that when we were talking about different approaches. You know, I think we don't have the same body of literature, and so a lot of times when we're trying to do these things, we're trying to base it off of what we have proven works. But I'm always very careful to say that just because we haven't proven or had as much experience with something, that means it's a useless or harmful tool. So it's not something that I have not had any patients come to me via diagnosis that way, but when I've spoken in these sort of sessions in the past, it typically comes up, and there's probably some value to it. It's just not something that I'm seeing a lot of cancer patients come to me because of that.
I've had friends who had the radiation and the chemo treatment for breast cancer. What are the side effects of the hormones?
Yeah, so it depends on the age, and not actually the age, but whether you're still getting your periods or not, the drugs that are used, and so there's some differences in side effects there. But some of the drugs have bone density issues, so we have to check someone's bone strength, and then this gives me a chance to again say if you exercise and do weight-bearing exercise, that's a really good natural way to increase your bone strength. Some of the other drugs have more of a risk of clots or strokes, and so those increase that risk factor. So before those can be prescribed, we just have to pay attention to what the person's baseline risks are and what we think the benefit is that they're going to get from that medication to determine if it's worth taking that medication. Not every woman is a candidate for that. We call it endocrine therapy. That's kind of we say chemo, radiation, and endocrine therapy, and not everyone is a candidate for it because there's certain receptors on tumor cells that we look for, and if a person is lacking those receptors, they're not going to get a benefit from that treatment. So it's extremely unlikely that we'd recommend that treatment to someone who is very unlikely to get a benefit from it.
So like we said, again, breast cancer treatment has become so individualized. You know, we're looking at your receptors, we're looking at the specific mutations that the gene, the tumor itself, presents. So your friend may have had a breast cancer 2 months ago and you're getting treated completely different. That's because we're really treating you different. It's not cookbook as it was even 10, 12 years ago. It's very individualized.
What about reoccurrence rates? If you just, if you either have like a lumpectomy or just mastectomy of one side, what is the recurrence rate?
You want to talk about the mastectomy and the bilateral mastectomy trends? Yeah.
We've seen an increase in, mastectomies and bilateral mastectomies, and all the studies are showing that really it is overkill because just treating the breast cancer with the lumpectomy and the radiation versus a mastectomy, when you look at the overall survival down the road, it's not really going to change it. Can you get a recurrence if you have a lumpectomy? Yes, you can get a recurrence as long as you have breast tissue. But when it affects your overall survival down the road, it really doesn't change that number all that much. Can you still get a recurrence with a mastectomy? Yes, you can. It depends on how aggressive the cancer was to start off with. So we're looking at that actual tumor itself to determine really what is that risk factor of the breast cancer coming back. And that's when, again, when we look at plug all that information into the computer, we do what's called an Oncotype testing score, we get that, or Mammoprint is another one. And then also now Dr. Hong is giving us other markers. As we're getting more advanced, we're looking at, Key 67. There's different markers that we're looking at that all gives us the recurrence rate. So we really need to look at the tumor individually now. It's not really related to just I had a mastectomy, I had a lumpectomy. That's not really what's influencing the recurrence. It's actually the tumor biology that's affecting the recurrence rate.
There's one piece that I thought of when you were asking that question. So we can use our best statistics to give an average risk of recurrence, and typically studies talk about 5 years, 10 years, 15 years, 20 years. And with breast cancer, no matter what treatment you do, that risk does continue, but our treatments lower it. The one thing that people ask me all the time, and I have a lot of breast cancer patients, so I hear this frequently is, well, I'm 5 years out from treatment, I'm cured, right? My breast cancer is gone, it's been 5 years. And in the oncology world, we don't often say to someone when they hit that magic 5-year number, you're cured. And that's not because something bad has happened, it's that something really good has happened, and we've gotten very good at treating cancers, not just breast cancers, but many types of cancers. And so it used to be that if that cancer didn't kill you in those first couple of years and you made it to 5 years, chances are you were going to make it. Now our treatments have gotten so good that we've got so many more people surviving, and we know that 5 years is no longer a valid cutoff. We have to follow a cancer patient for the rest of their life. And this is very true in breast cancer because there doesn't seem to be a plateau of your risk of that cancer coming back or getting another breast cancer. So you're not dismissed after 5 years. Your treatments may change, your appointments may become far less frequent, but we won't say, you're done. Right, you have to keep coming.
For a time, we were hearing quite a bit about women that were choosing a double mastectomy to reduce their risk.
Right, and so that,
Lately, there hasn't been much. Is it kind of quieted down? Or?
Well, it just takes a couple really famous people, and I can't even name the really famous people because I mostly live under a rock. I'm either at the clinic doing this sort of thing or manning the circus at home, so I don't know who those famous people were, but I know they existed. And so that led to a real story. Even my sister-in-law had both of her breasts removed for a DCIS, so a non-invasive cancer. There is no proven survival benefit to doing that. It may change your thinking and your worry and your anxiety. And my sister-in-law is a radiologist, so she had access to that literature and she still chose that. So I believe that that's a very powerful thing. But unless there are some other, there's always nuances, unless there are some other conditions that are uncommon but can be present, there's no need to have your breasts removed. Go ahead.
Breast cancer awareness for men.
Men can get breast cancer.
Yes, would you speak to that, just a bit, raising that level up?
Well, I think the first thing to know is that men can get breast cancer. It is far more common in women, but it can happen in men. It's a little bit easier to see and feel in most men, and it's actually treated very similarly. So I've given men radiation. I'm sure you've taken out.
I've done mastectomy.
Yep, so there isn't that much difference. It can happen, it does happen, it's typically managed the same way. It should not be ignored. The same message we gave you. You've got to come in if you have a breast lump, no matter what your gender is. You don't need to have those there.
I had two questions. One, I think you already answered the question about it's just trying to think of that acronym, but anyway. Yes, that's the one. But my other question also was, is just an inquiry question, because there's a lot of articles out now about, well, you shouldn't do chemotherapy or you shouldn't do radiation because it's just making you even weaker to fight your disease. What do you say to those kind of articles?
Well, it's true that our treatments have side effects. It's true that we have evidence that they improve your cure rate. So when people come in, I have to tell everyone about every possible side effect that could occur. Chances are they won't occur, but we don't treat people who don't need it. There's a lot of fear. There's a lot of fear. I have a lot of patients who don't believe in the treatments or who think that maybe the government has a cure and we don't know it yet. So that's out there, and it's really prevalent on the internet. What I would recommend is if you find yourself reading those sorts of things, ask us and we can guide you to some really good evidence-based websites that will only recommend treatments if we think that they'll benefit you. And there are times where we don't recommend the treatments because we think that they will cause more harm than benefit. I think Nan's up here. I think that means we're done.
No, it's not 9 o'clock.